அப்புறம் அதே மாதிரி ரிஃப்ளக்ஸ் எபிலிப்சி.
என்ன கேட்ட? refractory epilepsy.
ரிஃப்ளக்ஸ் ரிஃப்ளக்ஸ் எபிலிப்சி.
I also
அந்த
forgot what
காஃப்
is
பண்ணும்போது
reflex.
ஒரு மாதிரி அந்த காஃப் பண்ணும்போது சீஷர் வந்துடும், இல்ல மிக்சுரேஷன் போகும்போது சீஷர் வந்துடும். அதுக்கு ட்ரக் ஆஃப் சாய்ஸோ இல்ல அதுக்கு எப்படி டயக்னோஸ் பண்றதோ இல்ல அது கிளினிக்கல் மட்டும்தான்னா அப்ப அதை எப்படி ப்ரிவென்ட் பண்றது? இப்போ காஃப் மிக்சுரேஷன்னா டே டு டே ஆக்டிவிட்டி, அதை பண்ணாம இருக்க முடியாது. அந்த டைம்ல சீசர் வருதுன்னா சம்டைம்ஸ் வி ஆர் அவர் ஆன்சர் டைட்ன்ற மாதிரி இருக்கு. ஆன்டிசீசர் மெடிகேஷன் போட்டிருக்காங்க, பட் ஸ்டில் பேஷண்ட் வருது. நானே வந்து 2-3 கேஸ் இங்கே இங்கே வார்டில் ஒன்று ஐசியூல ஒன்று இன்னும் பார்த்த மாதிரி ஞாபகம் இருக்கு. அது ஒரு டாபிக். ரிஃப்ளக்ஸ் எபிலெப்சி, பிரேக் த்ரூ சீசர்ஸ் ஒன்று, இன்னொன்று நார்சியெல்லாம் நம்மளே பார்த்துருக்கோம். 1-2 கேஸ் ஐசியூலாம் இருந்துச்சு.
Reflex epilepsy, I don't have much of idea. Like we have seen cases, but actually most of the cases which are labeled as reflex epilepsy may be pure syncope, cough syncope, sneeze can produce syncope, micturition can produce syncope. So, but there's an entity called reflex epilepsy, that is true, but in such cases it is better always to rule out syncope rather than label them as seizures. That is one. Regarding your breakthrough seizures, most of the time what we tell is breakthrough seizure which occurs even though they are not withdrawn from the drugs. When they're taking the drugs, they are having seizure. That is called breakthrough seizures. It is not whether they are taking the drug or not. It is about the drug level in the body. Sometimes they may be taking the drug, but their therapeutic drug level may be inadequate. So for all cases of labeled as breakthrough seizure, first thing is try to rule out their adherence. Like in refractory epilepsy also we are discussing, right? Before labeling anyone as refractory epilepsy, first try to find out whether they are taking the drug properly. Second, if they are taking the drug properly, whether their level is proper in the body. Sometimes due to multiple drug interactions, the level may be inadequate. Third, even if they are very strict with the drugs, they may have some provocative factors which I told you. Sorry, like inadequate sleep or high emotional stress or menstruation, such things can be there. So all these things have to be ruled out in breakthrough seizure. Or there could be some provocative factor like electrolyte imbalance. These should be ruled out before labeling them as breakthrough seizure. Your breakthrough seizure is inadequate drug level in the body. Okay, any other doubts? We didn't discuss much about this treatment and epilepsy, like status epilepticus. I think till then we have discussed. Investigation we have discussed side by side.
Yes, sir.
Like why there's a difference of stages of status epilepticus? Like if you see in the table, just to show that flow
early
chart
refractory.
Yeah.
Early refractory.
பிரசாந்த் தானே இருக்கிறது போல.
ஆமா சார்.
See here, you should know about the stages of status epilepticus also. Status epilepticus by definition, as it told, any seizure activity lasting more than 5 minutes or separate individual episodes without recovery of consciousness is called status epilepticus. So more than 5 minutes but less than 30 minutes is called early status epilepticus or impending status epilepticus. 30 minutes to 48 hours is called established status epilepticus. Okay. Up to then more than 24 hours becomes refractory, more than 48 hours becomes super refractory. Why they have labeled this is the mechanism of action is different. In early or impending status epilepticus, there's some phenomenon called as GABA trafficking or neurotransmitter trafficking. That is why GABA antagonists like benzodiazepine will work in that early stage. But once 30 minutes crosses, the other neurotransmitters start coming into play, like NMDA, sodium and calcium. That is why we have a role of phenytoin, which is a sodium channel blocker, role of levetiracetam. Levetiracetam is a vesicle uptake inhibitor. So in the initial 30 minutes, there is a play of GABA, which causes status epilepticus. After 30 minutes, it is sodium and calcium, which is playing a role. But beyond that, it is starts having other changes like neuronal edema, etc., etc. So in that case only other drugs will act. So regarding this established status epilepticus, they conducted a trial called as ESET trial, Established Status Epilepticus Treatment Trial. So you told three drugs can be given: phenytoin 20 milligram per kg, or valproate 20 to 30 milligram per kg, or levetiracetam 20 to 30 milligram per kg. Which is best? According to this trial, everything is equally good. You can use anything. But whatever you use, try to use in the optimal dose. Very often we give only 500 milligram of levetiracetam in, it is significant underdosing. Because 30 milligram per kg for a 50 kg person will be 1500 milligram. So you have to give 1 gram or 1.5 grams minimum for a normal weight person. If they are obese, it can be even higher. So the dosage is important. Even in benzodiazepines, see the lorazepam dose is 0.1 milligram per kg. You have to give 5 milligram. Or midazolam is 0.2 milligram per kg, which is 10 milligram. 10 milligram is one full vial, right? We give only 2 ml, which is 2 milligram. It is highly inadequate. So most of the time problem occurs because of underdosing. So the dosage is very important. So benzodiazepine, midazolam dose is 0.2 milligram per kg. Phenytoin, valproate and levetiracetam is 20 milligram per kg to be simple. And if you are changing out infusion, it is 0.2 milligram per kg of midazolam. Propofol is 2 milligram per kg stat, followed by 2 to 10 milligram per kg for that. Remember the dose.
Yes, sir.
And these three terms you should be knowing. One is generalized convulsive status epilepticus. See, status epilepticus is a general term. Any seizure activity lasting more than 5 minutes is status epilepticus. If it is causing generalized tonic-clonic seizure, it is called generalized convulsive status epilepticus, GCSE. If it is an absent seizure which is progressing, it is called as non-convulsive status epilepticus.
Non-convulsive.
Okay. Then if it is a partial seizure which is continuing, it is called as epilepsia partialis continua.
Continue. Yes, sir.
Yeah. So we have three different things. Three are treated differently. If the generalized convulsive status epilepticus, first thing is midazolam. Next is phenytoin. If it is not settling, you directly go for midazolam infusion. Whereas if it is a non-convulsive status epilepticus, we can give another dose of phenytoin or levetiracetam or valproate, and here comes the role of lacosamide. It is also given in the chart which you mentioned.
Yes, sir.
Why this non-convulsive status epilepticus is important is they will not be throwing seizures. So they'll be presenting like a frank coma. So most of the cases which we label as metabolic encephalopathy or coma who become unconscious in the ICU, one of the differential diagnoses may be non-convulsive status epilepticus. There comes the role of your continuous EEG, which you told. So for a patient in coma, if you are able to monitor their EEG, if there is abnormal electrical activity, definitely they are in a state of non-convulsive status epilepticus. Then the treatment, as you told, the first line treatment for non-convulsive status epilepticus is midazolam, benzodiazepine, and non-sedating
long-acting anti-seizure medications like.
Yeah, you understand why non-sedating, right? Because if you give sedative, they'll be sleeping again.
Yes, sir.
So usually they say any patient, if you give midazolam, they become unconscious. But if a patient who is unconscious becomes awake on giving midazolam, then probably they are in a state of non-convulsive status epilepticus. So this is also a new trend. So most of the higher centers are doing this continuous EEG monitoring, 24 hours EEG monitoring. For centers which it is not available, prolonged EEG tries to, as I told. And EEG is the thing you have to remember is it is not doing an EEG. You mentioned while discussing about EEG, the changes in EEG is not important because any patient can have normal EEG changes, epileptiform changes. Whether he is having a significant criteria-based changes in EEG. Like for example, you mentioned initially in all the criteria when discussing the criteria, we should have 3.5 to 5 hertz spike and wave pattern to describe it as generalized tonic-clonic seizure. Diffuse slowing is an epileptiform abnormality, but it cannot be taken as a seizure. Okay, generalized slowing is like a metabolic encephalopathy. They say a triphasic pattern. It is also not audible. Hello. Hello. Am I audible now?
Hello, sir.
Am I audible now?
Yes.
Yeah.
Yes, sir.
So yeah, that's about non-convulsive status epilepticus. So generalized slowing or triphasic pattern, all these are EEG changes suggest of metabolic encephalopathy. So doing an EEG not only picks up NCSC, it can also tell you whether he is having a seizure or a metabolic change. So based on that, we can prioritize.
Yes, sir.
So any other doubts?
No, sir.
So one easy way to remember the drugs and the dosages is, I mean, oral form, I'm telling you. Most of the drugs, the starting dose will be 1 thrice daily. Maximum dose will be 3 thrice daily. For example, if valproate is available as 250 milligram, starting dose will be 250
Okay.
milligram TDS. Maximum dose will be 3 TDS. So like 200 is available means 6,800 milligram per day. Most of the time this will be correct. Exception is two. One is phenytoin, where the starting dose is 100 milligram thrice daily. Maximum dose is 400 milligram per day. Okay, so starting dose of phenytoin is 300 milligram per day. Peak dose is 400 milligram per day. And levetiracetam. Levetiracetam starting dose is 500 milligram twice daily. Maximum dose is 1000 milligram twice daily. For all most of the other drugs, starting dose will be 1 TDS. Top dose will be 3 TDS. Okay, I'll ask you a question. Is phenytoin plus carbamazepine a good combination?
So both have a similar mechanism of action.
Yeah, correct.
And
Both are sodium channel blockers. So there is no point in combining. You can combine
yes, sir.
phenytoin plus valproate because both are different action. If you combine two sodium channel blockers, it doesn't give an added benefit. That is why
Yes,
you
sir.
should know which the mechanism of action, like the classification of drugs, you should know which are the sodium channel blockers, which are the calcium channel blockers, okay, which are the GABA facilitators, which are the vesicle reuptake inhibitors. You told levetiracetam, brivaracetam, these are the vesicle reuptake inhibitors.
Yes, sir.
Most people use levetiracetam because they have no side effects. And levetiracetam
Yes,
is
sir.
either the first line or second line drug for most of the type of seizures. That is why we safely use levetiracetam. But which is the first line? If it is a focal seizure, try to use
Again,
lamotrigine.
both can be used.
Yeah.
Lamotrigine and
Hmm.
levetiracetam.
Yeah. If it is a generalized seizure, prefer valproic acid.
Yes, sir.
Carbamazepine has its role only in focal seizures. Okay. And you should know about the side effects also. Skin effects are common with carbamazepine, lamotrigine. Okay, sodium valproate. So which are the two drugs safe in pregnancy? We discussed. Levetiracetam
Yes,
and
sir.
lamotrigine.
Levetiracetam, lamotrigine.
And lamotrigine. Yes. So which drug causes hyponatremia among these?
Lamotrigine.
Many drugs can cause it. Carbamazepine. Many drugs can cause SAIDH, right? Carbamazepine,
Oh, yeah, I think a
oxcarbamazepine.
whole.
Yeah,
Yes,
pregabalin.
sir.
Is there any role of steroids in seizure?
If the underlying cause is vasogenic edema, like in case of CNS infections,
Okay, one is in
then steroids
meningitis
has
and
a role.
encephalitis. Okay, one is in meningitis and encephalitis. In addition to antibiotics, we have to use steroids. Second, autoimmune encephalitis.
Autoimmune encephalitis is common.
Third, as you told,
And then,
vasogenic edema.
yes, immunomodulation as a part of immunomodulation in refractory status epilepticus. I think methylprednisolone has been tried.
Yeah, in new onset refractory status epilepticus, we'll give steroid.
Honestly.
So, like it's an add-on. Okay. One more. West syndrome.
Okay, sir.
In pediatric West syndrome, we give ACTH. That's how we learned, right? But ACTH stimulates steroid production in the body. So now the trend is to give steroids for West syndrome. Okay. Then what else? Levetiracetam versus brivaracetam. Like we are speaking about refractory epilepsy, right? Two appropriately chosen adequate dose of anti-epileptic. If they are still taking, they are having seizure. It is labeled as refractory seizures. Yeah. So drug refractory seizures, we have to give brivaracetam, perampanel, or other drugs like clobazam, etc., topiramate, etc. Brivaracetam is the next version of levetiracetam. Remember, levetiracetam is the next version of pyracetam. Pyracetam is neutrophil.
Yes, we use common.
Yeah, so pyracetam has anti-seizure property. That is why it is a very good neuroprotective. Its upgraded version is levetiracetam. The main side effect of levetiracetam is psychiatric side effect. So levetiracetam may not be good in patients with a psychiatric background. Brivaracetam scores over levetiracetam in that brivaracetam is used as a treatment for refractory seizures, plus it does not have that much of psychiatric side effects. In your slide, you mentioned brivaracetam has psychiatric side effects, but it is not so common than levetiracetam.
Okay. Sir, for drug-resistant seizures, brivaracetam, perampanel, clobazam are all add-on drugs or
add-on drugs. In addition to the first drugs only, you should be giving. We can never we can never stop the first two drugs. See, even in your strategy, in your monotherapy, we are discussing. The best way is to give monotherapy.
We have to continue the old drugs. Regimen if it is drug resistant, right?
Yeah. Most of the time, see, here you mentioned most of the time, drug refractory epilepsy is not an epilepsy at all. Patient may have other diagnosis. Like it could be a syncope which is labeled as seizure. I told you, right? If you open Google Scholar and put syncope versus seizure, a case report will come. 17 years, a girl was treated like seizure, but actually it was a syncope, an arrhythmia of young age causing syncope. Similarly, PNES, you are mentioning the term psychogenic seizure, but now it is called as paroxysmal non-epileptic seizures. So psychogenic non-epileptic seizures. PNES may be a differential diagnosis. So most of the cases of drug refractory seizures are not seizures at all. So the investigation of choice for refractory seizure will be a video EEG. Yes. So, and you are speaking about the surgeries as a treatment for epilepsy, right? That is also that also comes in the concept of refractory seizures only. Only when a refractory seizure is there, first we have to confirm whether it is a seizure or not by doing video EEG. And always, I was telling initially, right? The ictal zone, symptomogenic zone. Okay, so we have to correlate their symptoms with the EEG thing, whether it is correct or not. Then there comes the role of your magnetoencephalography, SPECT, PET, etc. Because even if an MRI does not detect any ictal focus, these tests, like these special tests can find out an ictal focus. Functional MRI. When the patient is having a seizure, if you are doing a functional MRI, we can find out from where the seizure is originating, the ictal onset. So by doing a surgery, we can remove that ictal zone. So there comes lobotomy, lesionectomy. Yeah, you are showing in the slide, right? Lesionectomy. Where does corpus callosectomy come? Corpus callosectomy is one treatment in Lennox-Gastaut syndrome.
Okay, okay.
Any other doubts? If no doubt, shall I summarize in my style from starting to the end? In
Yes, sir.
2 to 3 minutes, I'll summarize. So seizure and epilepsy, you should know what is seizure. Seizure is basically a symptom which occurs due to abnormal electrical activity in the brain. It may be a sensory symptom, it may be a motor symptom, it may be an ophthalmic symptom or whatever it is. So seizure is basically a symptom due to abnormal neuronal activity in the brain. Epilepsy has 3 definitions. One, seizure can be technically classified as symptomatic seizure or provoked seizure and unprovoked seizure. So epilepsy is defined as 2 episodes of unprovoked seizure or 1 episode of unprovoked seizure which has a high risk of recurrence or a defined epilepsy syndrome. So we discuss the types of epilepsy. Grossly, we classify it as generalized epilepsy, generalized seizures and focal onset seizures. Focal onset seizure with impaired awareness, focal onset seizures with intact awareness. Then we have many other types: atonic seizure, absent seizure, pure tonic. Like that is not so important. In pediatric seizures, always think febrile seizures are the most common in 1 to 5 years of age. Before 3 months of age or before 1 year of age or after 5 years of age are atypical features. So you are mentioning the typical features of febrile seizures. Simple febrile seizure should last less than 15 minutes. It should be brief. And simple febrile seizure should occur at the peak of fever. So it never occurs on day 1. It will occur only when fever is very high, maybe on day 2 or so. But if seizure occurs even before the start of a fever or immediately after fever starts, it is complex febrile seizure. Complex febrile seizure may progress to epilepsy in future. So, very young age of onset, multiple seizure episodes in the same patient, associated other neurological symptoms, refractory to routine anti-epileptic medications. In that case, you have to think of syndromic analysis. Syndromic analysis maybe you have to do a genetic workup, and MRI is very, very important. Yeah, MRI is very important in this scenario because we have to pick up lesions in the temporal cortex, mesial temporal lobe, anything is present. So, and we are discussing about the causes. Right. So based on every age, you have to think about the most common causes. So in middle age, trauma is the most common cause. It is not alcoholism. It is not drug. It is trauma. So that were the causes we are trying to discuss. And then for any patient, we should have these 4 features in mind: the predisposing factors, epileptogenic factors, provocative factors, and provocating factors. Okay. So we have to treat everything. So any epileptogenic factor is any structural abnormality in the brain. Predisposing factors are family history. Provocating and predisposing factors are provocating factors are electrolyte abnormalities and sleep disturbance, etc. All these have to be addressed. So whenever any patient comes, this is the basic routine which you have to follow. You have to rule out all these factors, starting from acid-base analysis, electrolyte analysis, calcium, magnesium, sugars, even toxic analysis can be done. Infection analysis, including lumbar puncture, should be in the back of the mind. If something is identified, treat. If something is not identified, go with the EEG or MRI finding. So that is how you label epilepsy. In the treatment also, first episode of seizure, you need not treat everyone. Second episode of seizure, you must treat. When will you treat a first episode of seizure as a case of epilepsy? There's a family history of epilepsy or EEG showing abnormality, MRI showing abnormality. In those cases, first episode may be treated or based on the physician's choice if you think that patient has a high risk of seizure. And before thinking about the drugs, always know the mechanism of action. You should know the nerve endings, neurotransmitters in the brain, how they act. So which are the sodium channel blockers, which are the calcium channel blockers, which are the GABA facilitators. Only if you know that, we don't mix medicines unnecessarily. Try to prefer monotherapy approach. If you are trying to add a second drug, add the second drug when the first drug is going on and try to reduce and taper of the first drug. Or let the first drug go, try to add the second drug. That's an add-on approach. So a sequential approach or add-on approach is there for stable seizures. And uh, yeah, and we are discussing about status epilepticus in detail, types of status epilepticus and the protocol. ESET trial also we discussed. And few names were catamenial epilepsy, sudden death in epilepsy, NORS, new onset refractory status epilepticus. And you didn't mention about complications of status epilepticus, right?
Yes, sir.
Hypoxia. One is most important is hypoxia. Two is aspiration pneumonitis. Third is rhabdomyolysis and AK. So we'll be treating seizure, but we'll be failing to address rhabdomyolysis. Patient will be going in for AK. The recurrent seizure will cause cerebral edema. So we should address the cerebral edema by giving proper sodium supplementation and all. Okay. And some special things we discussed where to give steroids in epilepsy, role of diet in epilepsy. Like pyridoxine can be supplemented for refractory seizures. And medicine-induced seizures is very, very important. You should portray a list which antibiotics cause seizure. Even acyclovir can cause seizure. Tramadol cause seizure. Tramadol is commonly injected for pain, so tramadol can cause seizure. Okay, so I think that will do. So if someone asks you about seizure or epilepsy, you should know the definition, types, then how to investigate, what are the factors which you should consider, like provocative factors and all. Then the etiology as per the age. Then treatment, what are the drugs available, how will you start treatment, the dosage of each drug, and about status epilepticus, the protocol of status epilepticus, complications. So that's all in short, the synopsis of seizure and epilepsy.
Yes, sir.
Okay.